This conference will now be recorded.
Can you hear me?
Yes, ma'am.
Okay. Okay. So we will start today. Actually, there was 2-3 days gap. So today we will discuss this part 2 HMB talk. Okay. And this is regarding the procedures. Okay. Procedures means hysterectomy and myomectomy. And this talk is very important because you get EMQs. Most of the time you don't, because NICE guideline, they have not clearly mentioned regarding which route of hysterectomy, what hysterectomy, and when to do hysterectomy, when hysterectomy is preferred. So for all these things, this talk is very important. This talk, and I have included some a part of strategy also in this talk. Okay, so that your understanding will be very clear with regarding this hysterectomies. So first in this talk, what they have discussed is the myomectomy. So as you know, fibroid prevalence is very high. So lifetime risk is 70% for white women, and lifetime risk for fibroid for black women is around 80%. Okay, so 70% lifetime risk is for white woman and 80% lifetime risk for black woman of having fibroids. Now, removal of fibroids, it does not guarantee that it will normalize the menstrual loss, but large and intracavity lesions, if the removal, if they are removed by myomectomy, they will result in significant reduction in the menstrual loss. So not normalization, but significant reduction in the blood loss or menorrhagia will be there with the removal of large and intracavitary fibroids. And another thing, what is the evidence-based, what they have found out is myomectomy is the only surgical option if fertility is required. Okay, and there is good evidence to support that removal of submucous fibroids, it increases the pregnancy rate. Now remember, well, there was one SBA previously also in one exam ki only submucous fibroid myomectomy will only increase the pregnancy rate, while my intramural fibroid myomectomy will not. They have still evidence is not in the favor of myomectomy to increase the pregnancy rates. Okay, so only what is the evidence is there is only for submucous fibroids to increase the pregnancy rate. Now fibroid classifications, there are three systems of fibroid classification. One is the Wemstecker classification, where they have classified only submucous fibroid into type 0, type 1 and type 2. Okay, so type 1 is totally intracavity. Type 1 is more than 50% of the fibroid is intracavity, and type 2 is less than 50% of the fibroid is intracavity. That is Wamsteker classification. Another one classification is the FIGO or European Society of Classification. Okay, and then last classification is Step W classification. It is done by Lasmer. Step W means it is S for size, T for topography, E for extension, P for penetration, and W for lateral wall extension. So this is the this classification by Lasmer. It is more helpful when you are planning for the fibroid treatment, and also it has shown that it predicts better regarding the likelihood of this hysteroscopic myomectomy. So this is the Step W classification. Here you can see score has been assigned for this all Step W, that is size, topography, extension, penetration, and lateral wall. And total score you have to calculate. And depending upon that, when the score is 0 to 4, there is most of the time hysteroscopic myomectomy is possible. There will be very less complications. 5 to 6 score, it is a high complexity hysteroscopic myomectomy. Consider JNRH use, and it may require 2-step procedure also. Well, 7 to 9 score, when the score is 7 to 9, you should consider other alternatives than the hysteroscopic myomectomy. And this is a classification depending upon the cavity or depending upon the location. So here you can see 0, 1, 2 is for submucous, 3 to 8 is for other, that is from intramural to subserosal, and hybrid leiomyomas can also there. So here you can see 2 to 5. 2 to 5, this leiomyoma is there. It is extending from intracavity to subserosal also. So it is hybrid fibroid. So it has been given this classification as 2-5. Okay, so here two numbers are separated depending upon the location. This is not important, just remember. So these are the different types of classification, and which classification is more important for hysteroscopic possibility of myomectomy is Lasmer's classification or Step W classification. Now regarding hysteroscopic myomectomy, submucous fibroids, these are the likely cause of abnormal uterine bleeding and subfertility, and most are amenable to hysteroscopic treatment. Either it can be full or partial removal. So usually the common technique employed for hysteroscopic myomectomy is surgical resectoscope, and usually for type 1 and type 2 fibroids. So for type 0 fibroid, they are almost intracavitary. So there is no need to dissect the uterine wall. But for type 1 and type 2 fibroids, when we start resecting the fibroids, they get extruded into the uterine cavity. And if we continue the resection, there is chance that we may perforate the uterine cavity. So to avoid this, intraoperative ultrasound can be used to see the myometrial thickness, and depending upon that we can decide how much to dissect or how much to regarding the depth of this resectoscope penetration. Also sometimes for type 2 fibroids it may require two-step procedures 4 to 6 weeks apart, okay, and it becomes safe, and also complete removal of fibroid will be possible in case of Lasmer group 2 and 3 lesions. So, as I told you, grade 0 and grade 1 fibroids, they are easily removed by hysteroscopically. Difficulties are encountered with grade 2 fibroids because most of the fibroid lies in the myometrium. So, here the most important factor in determination is thickness of myometrium between the fibroid and serosa. Okay, so whether it is amenable to hysteroscopic resection or not, the deciding factor will be thickness of myometrium between the serosa and the fibroid wall. So full thickness lesion should be only saved to the level within the cavity and it should be left. So it is for type 0. Then as I told you, for grade 1 and grade 2 fibroids, they are extruded into the cavity once we start using resectoscope. And for grade 2 fibroids, we can use GnRH analogs also to reduce the fibroid size and also to avoid this fluid overload. But there is inconclusive evidence regarding the reduction in operating time. Now another thing is, so when the submucous fibroid is more than 5 centimeter in diameter, so here the preparation with GnRH analog should be done by experienced hysteroscopic surgeon. So this surgery should be done by only experienced hysteroscopic surgeon, and only if it is deemed to be the most appropriate option after consideration of other alternatives like uterine artery embolization and hysterectomy. So submucous fibroid more than 5 centimeters, see if the family is complete. I'm telling you for the EMQ purpose. So if the submucous fibroid is more than 5 centimeters, if the family is complete, better to go for this patient for hysterectomy. Okay. If the fertility is required, it will be hysteroscopic myomectomy. Okay, and for intramural fibroid of similar size, it is better if she wants uterine conservative option, it is UAE. Okay, if she doesn't want surgery, so it will be there in your question whether the patients want surgical treatment or not. Okay, so depending upon that, it will be decided whether you want to go for myomectomy, whether you want to go for hysterectomy, or whether you want to go for uterine artery embolization. Because most of the time, the EMQ comes regarding this fibroid, and they will give all options. So you have to choose the most fitted or most suitable option. Now, hysteroscopic myomectomy techniques. So there are as I told you, one is resectoscope, another is cold loop technique can be used. What happens with this cold loop technique is less synaptic formation because less diathermy is used in the endometrial cavity. But this is more relevant for fertility conservation rather than the treatment of HMB. Also, miniature morcellators are there which can be used through the hysteroscopic channel, operative channel, and smaller fibroids can be shaved. Okay, so it is very easy to remove these fibroids also, because if you resect also these fibroids, the difficulty will be there while removing those from the cervical os. So miniature morcellators are also there. So from this you can use to remove this fibroid fragments, okay, to make this fragment the fibroids. Now other managements, That is, one is UAE and another is magnetic resonance guided focused ultrasound technique. So these are the two techniques. There is another talk regarding fibroid management in 2016. Okay, it is also, this medical management is detailed discussed in the 2016 talk on fibroids. So medical management and non-invasive techniques are effective in alleviating symptoms associated with uterine fibroids. But when the fertility is concerned, still there is no evidence available regarding UAE or MR-guided ultrasound technique. So these two options are not considered if the fertility is needed to be preserved. For hysteroscopic myomectomy, traditional resection is the still gold standard. So, as I told you, there have been reports of successful pregnancies after UAE or MR-guided ultrasound treatment, but further randomized trials are needed to prove the safety of these treatments in young women where the future fertility is desired. So, the meaning of this sentence is, when the question comes in your EMQ, whether the patient wants to preserve her fertility, you should not choose these options, that is UAE and MR-guided ultrasound treatment. Now, regarding abdominal myomectomy. So, abdominal myomectomy, as I told you, it is only for the relief from pressure symptoms and for menstrual relief. Okay, and women wishing to retain their fertility. But intramural fibroids, they don't have evidence that removal will increase the fertility rates or pregnancy rate. Myomectomy is most commonly undertaken by open laparotomy, although there is significant morbidity associated with these procedures. Also, adhesions to the myomectomy wound are common. Also, hemorrhage is also common. So, these adhesions can be reduced by careful attention to hemostasis, tissue handling, and possible use of anti-adhesion products. And blood loss can be reduced during myomectomy, either by GnRH analogs, that is preoperative GnRH analogs, or use of intraoperative tourniquets or vasopressin. So for abdominal myomectomy, which routes to be chosen? Either laparoscopy or open. Now, one thing is there, robotic surgery should not be used according to NICE guidelines. They have discussed this robotic surgeries, but remember that robotic surgeries are only used for experimental trials till now. So if the option is there, robotic surgery, no, you should not choose that option. Now you have to decide between abdominal and lap myomectomy. So for abdominal and lap myomectomy, depending upon the size and multiple fibroids. So for single fibroid, definitely you can choose lap myomectomy. But if multiple fibroids, if they have given it is a very large uterus and multiple fibroids, better to choose for open myomectomy. Because using in this slide they have given that minimal access surgical approach, laparoscopic and robotic, they can significantly reduce tissue handling and speed post-operative recovery, but the limitations are size, number and position of fibroids, which will determine whether it is feasible to undertake the surgery laparoscopically. So whenever there are multiple large fibroids, the route of choice will be laparotomy or open myomectomy. While for single small fibroid, the route of choice will be laparoscopy. Now regarding the laparoscopic myomectomy and morcellation, the recent debate regarding this. So preoperative shrinking the lesion with GnRH analogs, it may improve the chances of successful lap surgery. But there can be a loss of obvious tissue planes delineating the myoma. Also now there is, as a morcellation techniques have been there, so it allows the removal of large amount of tissue through a 12mm port. But the rate limiting steps for this lap surgery are access and requisite minimal access surgical skills and training. Now the recent concern regarding the morcellation, that is your disseminated malignancy, increased risk of disseminated malignancy. So in US FDA, what incidence they have found is 1:350. 1:350 incidence of malignancy in morcellated segments. But while recent studies or recent evidence has shown that this risk of malignancy in fibroids is less, it is much lesser, that is 1:2000, and malignancy is more likely in postmenopausal women where the morcellation should be avoided. So in postmenopausal women, morcellation should be avoided. Again, RCOG has published one consent advice regarding morcellation. So you should remember that consent. Now, in that consent advice, there is not much numbers are there. Only thing, this is the single 1 or 2 number regarding this malignancy. But finally, what they have given is significantly within shorter duration, significant increase in size, postmenopausal. These are the patients, and the patients who are not where the size has not decreased with medical management. Okay, large solitary lesions where these fibroids, they are not responded to treatment like GnRH analogs or uniprestal. These are more likely to be malignant. So in these patients, morcellation should be avoided. But presently there is no diagnostic test, either radiological or hematological, that can reliably rule out any malignant growth. Okay. So now the what is the alternative they have found out is morcellation in the bag. But again, morcellation in the bag, the technique is difficult. It requires specific bags, and also the learning curve will be difficult. Okay, and also it increases the new risk like intestinal injuries. So full understanding of this procedure and requisite training are essential for this intra-bag morcellation. So this is regarding the myomectomy. So for myomectomy, the thing what you should remember is submucous myomas. Myomectomy of submucous fibroids, it increases the pregnancy rate, while that of intramural myomas, it will not increase the pregnancy rates. Okay, that is the one thing. And for HMB, instead of hysterectomy, the good treatment is myomectomy, and myomectomy, depending upon the number and size of the fibroid, you have to choose either by open or lap. And when the patient doesn't want surgery and when the patient doesn't want to retain her fertility, you can also go for either UAE or MR guided ultrasound treatment. Now regarding hysterectomy, hysterectomy is the most common surgical procedure performed in gynecology. It is the most common major surgical procedure. It is the only surgical procedure that can guarantee amenorrhea and remains definitive form of management of HMB. Now you remember these two keywords, because sometimes they ask, patient wants definitive treatment for her HMB. Okay, her family is completed, patient wants definitive treatment for her HMB. So the option there will come as definitely it will be a hysterectomy. Okay, if she wants definitive treatment, the treatment option is hysterectomy. Okay, so because most of the time it is, these are the words that you have to be very this thing that you should be very careful regarding these words, and if you find such words, you should choose the correct option. Now hysterectomy, either it can be total or subtotal. So subtotal means cervix is retained. Total means uterus and cervix both are removed. Now, the difference between subtotal and total hysterectomy. So the preference, what happens with total hysterectomy is there is guarantee that there will be no bleeding and no further smears are required. So this is the thing that will goes in the favor of total hysterectomy. But morbidity is somewhat greater with total hysterectomy, and also there is increased risk of hemorrhage. Okay, so morbidity is greater, increased risk of hemorrhage is there with total hysterectomy. When you consider lap or minimal access surgery, subtotal hysterectomy is a simple procedure which avoids bladder dissection. So the morbidity definitely decreases and the operating time also decreases. Also, it will be significantly reduce hospital time and earlier recovery in case of lap subtotal hysterectomy. Now remember well, recovery time for both open total and subtotal, it is almost same. Okay, so subtotal recovery time for total and subtotal hysterectomy by open technique, it is same. But while for laparoscopy, recovery time for subtotal hysterectomy is much lesser than the total hysterectomy, that is total lap hysterectomy. Now, subtotal hysterectomy is a choice of procedure for difficult hysterectomy, where the removal of cervix is considered difficult, like grade 4 endometriosis. So, if you get a question like grade 4 endometriosis with adhesions, the option will be subtotal hysterectomy. Okay, grade 4 endometriosis with presence of adhesions. In that case, the option will be subtotal hysterectomy. So please be attentive towards these keywords. Now, usually it is argued that leaving the cervix, it will retain the anatomical supports of uterus and minimize the injury to nerves, to the bladder, bowel, and sphincter, and also reduce the risk of prolapse, bowel, bladder, and sexual dysfunction. But the Cochrane review did not find any significant difference between the prevalence of urinary incontinence, voiding dysfunction, constipation, fecal incontinence, sexual function, and dyspareunia. So remember well, subtotal and total hysterectomy, the Cochrane review didn't find out any significant difference between all these things. Okay, so there will be no improved sexual function, there will be no increase in the incontinence rate, nothing. So all these things doesn't matter. Only the three things which matter is increased morbidity with total hysterectomy. Second thing is increased risk of continuing bleeding and need development of cervical carcinoma in the scrum. These are the only three things which are with the subtotal hysterectomy. So 5% women will have continuous cyclical bleeding after subtotal hysterectomy. This was a SBA and it was asked in one of the exam also. Also, their smaller proportion, they require future cervical stump removal for pain or sometimes rarely for malignancy. Also, there is no evidence of difference in sexual function between the women undergoing total and subtotal. So at present, until the superiority of total hysterectomy is established over subtotal, woman's preference along with surgeon's experience should be taken into account. Okay, so it is the woman's choice and also surgeon's expertise regarding whether to do a subtotal or total. So after hysterectomy, there is 2 to 7. This is the simple sentence that you should remember. This is the strategies, this thing percentage. After subtotal hysterectomy, there is 2 to 7% risk of persistent cyclical bleeding, 2% risk of cervical prolapse, and 1% risk of cervical cancer. This is the most important sentence that you should remember regarding the subtotal hysterectomy. There is no difference between STH, that is subtotal, and abdominal hysterectomy in terms of quality of life, constipation, prolapse, satisfaction with sex life, pelvic pain, vaginal bleeding, or complication rates. So these two are strategy sentences. Remember these two sentences well. Okay. Only thing is morbidity is more with total hysterectomy. Now regarding ovarian conservation during hysterectomy. So there are potential negative effects of premature withdrawal of ovarian hormones on cardiovascular disease, hip fracture, sexual function, and overall mortality in premenopausal women who have undergone BSO. So elective BSO under the age of 50 and who do not take hormone therapy, they are associated with higher risk of cardiovascular disease and it should be discouraged. Young women who undergo the risk-reducing BSO, in which deprivation of estrogen and testosterone occurs acutely, so there is high rate of female sexual dysfunction, hypoactive sexual disorders, lubrication difficulty, and dyspareunia, and orgasmic dysfunction also. So some of these effects can be reversed using HRT. So only the risk-reducing BSO has been performed in some who are at BRCA positive, BRCA1, BRCA2 positive, they require this risk-reducing BSO. So there is sexual dysfunction occurs with these patients. Now, 2015 Society of Gynecological Oncology recommendations, they recommend that for prevention of ovarian cancer, salpingectomy should be considered as an alternative to other sterilization techniques and it should be performed opportunistically at the time of hysterectomy or any other pelvic surgery. Okay, so salpingectomy should be done with any other pelvic surgery or it can be performed as an alternative to sterilization also. For premenopausal women with no evidence of hereditary ovarian or breast cancer syndrome, elective BSO should be discouraged based on the increased risk of cardiovascular disease and sexual dysfunction. So BSO should not be recommended, but opportunistic salpingectomy should be inversely encouraged. So ovaries BSO should not be done under the age of 50. Okay. Now which route to choose? Whether it is a vaginal, abdominal, or laparoscopic. Okay. So remember well, according to the cost wise and operative time, vaginal route is always preferred. So whenever there is comes for the route, always remember that vaginal route is always preferred, followed by laparoscopy, and last will be the abdominal. Okay. So the choice of surgical approach, it is dictated by the presence of pelvic or extrapelvic pathology, previous surgeries, body habitus, and other associated comorbidities and surgical expertise available. So here you can see the cost wise and recovery time wise and operative time wise, vaginal hysterectomy is much more superior. Even blood loss is somewhat, it is actually reduced with vaginal hysterectomy. But the only thing is renal tract injury is somewhat more with vaginal. Also, it is more with laparoscopic. Bowel injury is very less with vaginal hysterectomy. It is more with abdominal. And infective sequelae, these are more with vaginal hysterectomy. Now, regarding abdominal hysterectomy, so in which patient you should choose abdominal hysterectomy? So, it is a useful approach where there is coexistent pelvic pathology such as adhesions, endometriosis, ovarian masses, or large fibroids. Most procedures can now be performed laparoscopically. So in case of abdominal, first you should go for lap, okay? And when all these things are not there, you should go for vaginal hysterectomy, okay? So when the route is asked, it is the first preference will be for vaginal, but if these factors are present like adhesions, endometriosis, ovarian masses or large fibroids, you should go for either lap or open depending upon the other risk factors, okay? However, when there are large fibroids with restricted access for lab instruments, see, so larger fibroids or where morcellation has increased risk of disseminating malignancy, laparotomy is the sensible option. The NHS website states that laparoscopic hysterectomy is the preferred treatment method for removing organs and surrounding tissues of the reproductive system. Despite this and the fact that majority of women have with HMB, they have a uterus smaller than 10 weeks, 60% of benign hysterectomies in UK are still done by open abdominal route. This was also the incidence in USA over 10 years ago and in the UK over 20 years ago. Now regarding laparoscopic hysterectomy, the three things: what is laparoscopic assisted vaginal hysterectomy, what is laparoscopic hysterectomy, and what is total lap hysterectomy. So LAVH or laparoscopic assisted vaginal hysterectomy is the thing where laparoscopically what you do, only you divide round ligaments and infundibulopelvic ligaments. Other things are done by vaginal route. So laparoscopic assisted vaginal hysterectomy, you will only ligate round ligament and infundibulopelvic ligaments. And uterine downwards you will do by vaginal route. Lap hysterectomy means up to uterine vessel, the procedure is done laparoscopically, but the vault closure usually, the vault closure is done with vaginal route. So remember when the only vault closure is done with a vaginal route, it is lap hysterectomy. When uterine down, so from uterines it is done from vaginal route, it is LAVH. And total lap hysterectomy where the total specimen is removed via laparoscopically and then vagina, that is vault, is sutured laparoscopically. So it is called as total lap hysterectomy. So the completing the vaginal component of the procedure has been made much easier with the development of colpotomy cups, which present in the vaginal fornix for division and displace the ureter laterally. The use of colpotomy cups also allows the maintenance of uterosacral ligament complex in most cases, which also reduce the incidence of vault prolapse. Now, this laparoscopic assisted supracervical hysterectomy, here what you are going to do, as I told you, same thing you are going to do is just you will remove this round ligament and infundibulopelvic ligament by laparoscopy. Another component you will do by vaginal, and here the patient will usually go home within 24 hours and she can resume her activities and work within 2 weeks. Because here vagina is not usually open, so it reduces the risk of infection and there is no disruption of uterosacral complex. Bladder dissection is not required because cervix is transected above the levels. After securing the hemostasis of uterine arteries, the body of uterus is removed most commonly using a dithyramine loop around the cervix through the or a monopolar hook. And small uterine, small uterus, they are removed through colpotomy incision. So here the vaginal, it is not the vaginal hysterectomy. So here you are doing the total hysterectomy only by the laparoscopy. Here you are not going to open any vaginal part, but the uterus you are going to remove by colpotomy incision, or you can use a morcellator. Now, vaginal approach is the procedure of choice when hysterectomy is performed for UV prolapse. Non-distant vaginal hysterectomy for HMB is increasingly being performed to avoid abdominal root, and it is the recommended approach for benign gynecological conditions. The limitations for vaginal hysterectomy are uterus larger than 14 weeks of gestation and presence of concomitant ovarian pathology, and most pertinent is the surgical training. With the evidence that ovarian cancer, they arise in the febrile end, so there is a move to recommend prophylactic salpingectomy at the time of hysterectomy. It will be much more difficult by vaginal route, and it may favor a laparoscopic approach. So removal of fallopian tube, it also removes the risk of tubal prolapse through the vault, a cause of discharge, postcoital bleeding, and sometimes pain. So this febrile prolapse, it is avoided if you do the simultaneous bilateral salpingectomy also during vaginal hysterectomy. Robot-assisted hysterectomy, what you should remember is, it is actually advantage of 3D vision, intuitive learning with full range of instrument movement compared with the laparoscopic hysterectomy. It is a less risk of surgeon fatigue and spinal and shoulder problem. But the major disadvantages are absence of haptic feedback and excessive cost. So NICE guidelines states that the robotic hysterectomy should be limited to research purposes at present, because it is unclear whether it is safer or more effective than lap surgery. So continuing trials are likely to have an important impact on evidence related to use of robot-assisted surgery. But right now, robotic hysterectomies or any robotic surgeries at present, right now, is not a recommended option. Now, risk and complications of hysterectomy. This is actually better. You should do it from the consent advices. But what you should remember is overall complication rate with hysterectomy is around 4%. Most common complications, these are categorized as infectious, thromboembolic, genitourinary tract injuries, and gastrointestinal injuries, bleeding, nerve injuries, and vaginal cuff dehiscence. Infectious complications, these are the most common problem with wound, urinary tract, and respiratory infections. Injury to genitourinary tract, the percentage is 1 to 2% for all major gynecological surgeries, and 75% of injuries occur during hysterectomy. Bladder and ureteric injuries are more common at lap surgery, and it's usually related to the dissection around the cervix and securing uterine arteries. Injuries to GI tract, it is less common. The incidence is 0.1 to 1%. Bleeding complication and need for transfusion, these are also rare. So the median range of blood loss is 150 to 600 ml, with vaginal hysterectomy having lowest bleeding. Okay. Neuropathy, it is uncommon, but the rate is 0.2 to 2%. Vaginal cuff dehiscence, it is more common with total lap hysterectomy. This was also a question. I think it is a talk question also. So the most common, it is more common with total lap hysterectomy, and then with very less with vaginal hysterectomy. This is usually occur because of use of cutting dithyramine instruments to open the vault, less effective lap suturing, or earlier recourse to sexual activity. Now regarding the ovaries, women who have ovaries conserved at the time of hysterectomy, they are more likely to need future surgery than the women who undergo concomitant BSO. Vaginal hysterectomy, it is associated with increased hazard ratio of needing future pelvic floor surgery or any gynecological surgery compared with those who had either total or subtotal hysterectomy. And the reason for this is usually vaginal hysterectomy is done for prolapse, correct? So most commonly there will be recurrence of vault prolapse, and that is the reason that vaginal hysterectomy, the patient who have undergone vaginal hysterectomy, they are associated with increased risk of need of future pelvic surgery. Now, when you compare endometrial ablation versus hysterectomy, so hysterectomy is the only procedure that can guarantee amenorrhea. and it is more effective in the treatment of HMB in comparison with endometrial ablation. Satisfaction rates are higher with hysterectomy, but the difference was not statistically significant. But remember that hysterectomy, it is a major surgical procedure with associated perioperative and postoperative morbidity, longer convalescence, and delay in return. With the exception of fluid overload, other complications are very less with this ablation and they are more common with hysterectomy. So women undergoing ablation, they are 3.6 times more likely to require future gynecological surgery. So as we have seen in the previous talk, the rate is around 14 to 20% that may require future surgeries, and the majority of repeat procedures are either ablations or intrauterine procedures. So compared with the hysterectomy group, the women who underwent ablation, they were less likely to have other major surgeries like pelvic floor repair, incontinence surgeries, adnexal surgeries, or fistula repairs. Surgical damage to connective tissue or neurological tissue during hysterectomy, it could potentially compromise the pelvic floor, which increases the risk of surgery for future prolapse or incontinence surgery. So finally, cost effectiveness, when you compare cost effectiveness, usually ablation is less expensive than hysterectomy. But when you compare this cost effectiveness, it is with quality adjusted life years. Hysterectomy is resulted in the gain of more quality adjusted life years, and it is more cost effective in long run. So this sentence you should remember very well. So in long run, hysterectomy is more cost effective than the endometrial ablation. So this is the regarding this HMB2 talk. This talk is basically for the which procedure and which route you will choose for the HMB. Okay. So regarding the questions, please post your answers in the chat box. A 46-year-old woman underwent subtotal hysterectomy as treatment for HMB. What percentage of women who had subtotal hysterectomy will have cyclical bleeding? Yes, answer is it's B. It is 5%. Okay. Strategy answer is 2 to 5%. This talk gives the answer 5%. Okay. So answer is B, 5%. Next, a hysterectomy was offered to 37-year-old woman with HMB that was refractory to medical treatment. What is the main advantage of subtotal hysterectomy over total hysterectomy? Yes. Yes, as I told you, for subtotal hysterectomy, the only thing which goes in favor of subtotal hysterectomy is morbidity is lower. Okay, morbidity is lower. While all other things, there will be no better sexual function, there will be no reduced impact on ovarian function, there will be no reduced incidence of bladder dysfunction. Surgical expertise is it depends upon the surgical expertise finally. Okay, but the basic thing is what is the proven factor is lower morbidity with subtotal hysterectomy. Approximately what percentage of benign hysterectomies in the UK are still performed by laparotomy? It is more than 60%. Answer is E. Okay. So answer is E. It is more than 60%. So this finishes our today's talk. Tomorrow Thursday we will do. Friday it's not possible for me. Tomorrow we will do one more. Okay. Okay then. Bye friends.
Thank you, ma'am.
Thank you, ma'am. What talk tomorrow, ma'am?